So let us talk about achalasia today. Achalasia has two main etiologies. Number one, idiopathic. Number two, infection. Idiopathy is the most important cause for achalasia, which is present most of the times. On the other end, infection could be caused by Trypanosoma cruzi that will lead to Chagas disease. Number two, varicella zoster. Regarding the definition of achalasia, there are two terms used: aperistalsis and failure of relaxation of lower esophageal sphincter. Let me explain these two terms by means of an actual diagram to have a better concept. As you could see on the right hand side, there is normal esophagus with lower esophageal sphincter and stomach. On the left hand side, there is contracted lower esophageal sphincter with distal dilatation of esophagus. Now let me incorporate the pathogenesis with the signs and symptoms of achalasia. Talking about pathogenesis, failure of relaxation of lower esophageal sphincter is because of damage of the inhibitory ganglion of the neurons in the meningeal plexus. Now this will lead to absence of relaxation of the lower esophageal sphincter on the passage of food, which will lead to the second part of definition, that is aperistalsis of esophagus. Now this will cause hypertonic lower esophageal sphincter that will present in the form of retrosternal pain. Failure of relaxation of lower esophageal sphincter will cause dilatation of the lower esophagus, which will cause collection of food along with difficulty in passage of food. Now this collection of food and difficulty in the passage will present in the form of dysphagia and regurgitation. The dysphagia of patient of achalasia will have three characteristic points, which will not only be specific to achalasia, but the same 3 points will differentiate dysphagia of carcinoma of esophagus from achalasia. If the dysphagia is present in young age to both solids and liquids, and it is intermittent, it would be in a patient of achalasia. But if the dysphagia is present in the old age to solids first and it is progressive, it would highly suggest the patient is having esophageal carcinoma. Talking about regurgitation, it would be spontaneous and specifically present at night. Now after collection of food and difficulty in passage of food, the food will rot in the esophagus and the patient might present having bad breath. Now if the patient is having this problem and he is not diagnosed properly, he or she may even develop esophageal carcinoma. Now talking about investigations, first of all we have X-ray. X-ray will show dilatation of esophagus. Barium swallow is the second option. Barium swallow will show bird beak, or otherwise known as rat tail. There are 3 points which define this bird beak on a barium swallow, and they are dilatation of esophagus, collection of food, and gradual narrowing of the lower end of esophagus. Then we have manometry. Manometry is the gold standard for making a proper diagnosis of achalasia, but the disadvantage of manometry is that it is not available in all the hospitals. But if it is done, what would be the key features found on manometric observation? That is, increased lower esophageal sphincter pressure, incomplete relaxation of the lower esophageal sphincter on swallowing, and absence of peristalsis in esophagus. And then we also have endoscopy to exclude carcinoma and strictures. Now let me show you an actual barium swallow to have a better understanding that how a patient of achalasia will appear on barium swallow. Now this is the barium swallow in an achalasia patient. You can see with an orange arrow at the lower end that it is showing there is narrowing of the lower esophagus because of contracted lower esophageal sphincter. A bit higher to that point, there is dilatation of the esophagus, and this dilatation is because of collection of food because it cannot enter from esophagus into the stomach. So by far we have talked about different investigations which can help us make a proper diagnosis of achalasia. Once the diagnosis has been made, we will progress towards the treatment and management plan. There are 3 modalities which can be used to treat achalasia. Number 1, medical. Number 2, endoscopic. Number 3, surgical. Regarding medical management, we have calcium channel blockers and nitrates. Regarding endoscopy, either balloon dilatation or botulinum toxin can be used. Let me explain this endoscopic part of treatment in terms of diagrams. As you can see, in this diagram, an endoscope is used to pass the balloon dilator at the distal end of esophagus so that room can be created to allow the food to pass from esophagus into the stomach so that the dilatation that was produced because of contracted lower esophageal sphincter can be dealt with. Now, this is the other part of management through endoscopy, that is, by means of an endoscope, injection is sent down to the lower esophageal sphincter and botulinum is injected. Now, this botulinum will cause dilatation of the smooth muscles present in the lower esophageal sphincter and it will allow the passage of food from esophagus into the stomach. Endoscopic management needs to be repeated at regular intervals and it does not have an ample amount of success rate so that it could be used as a gold standard. The gold standard for achalasia is surgery, Heller's myotomy. Along with fundoplication, if Heller's myotomy is done alone, there are great chances that patient can develop GERD. So to overcome this complication, fundoplication is also done. So as you could see, this diagram has three parts, A, B, and C. In A part, contracted lower esophageal sphincter with entrapped food is shown. In B part, a longitudinal incision is given at the lower end of esophagus to allow the contracted lower esophageal sphincter to be relaxed, and the cardia portion of the stomach is stitched onto the anterior portion of esophagus. Now, I hope you have a much better understanding about how achalasia presents and what investigations we will do and what would be our treatment plan. So if you like my lectures, kindly like, subscribe, and share with your friends. Thank you.